Hello, my name is Hope Newport, and it is my pleasure to welcome you all to this session, When a Surgical Procedure is Your Only Option, Coordinating Expert Dental and Anesthesia Care. Thank you so much for taking the time to join us. Before we get everything kicked off, I wanted to review a few brief housekeeping notes. The chat box found below the video screen allows you to interact with each other and program staff, and we hope you'll use this opportunity to make some new connections. You'll see a Q&A tab located next to the chat. We encourage you to use the Q&A box to share your questions with presenters. Please note that the presenters may not see all questions entered in the chat area, so be sure to submit your questions in the Q&A field to help us get them answered. To the right of the Q&A tab, you'll see a Wordly tab. To utilize translation, please click that tab and select your preferred language. And as always, if you have any technology issues during this session, please feel free to put your question into the chat, and our engineer on the line will do his best to assist you. And now to begin our session, When a Surgical Procedure is Your Only Option, Coordinating Expert Dental and Anesthesia Care. Today, we have the great gift of hearing from an inspiring group of medical, dental, and anesthesia experts from around the world. You may see us a little small on your screen, so I wanted to bring to everyone's attention that you can resize this video window, by clicking an edge and dragging it. We are greeted today by Drs. Clive Friedman, pediatric dentist from Canada, Dr. Zvi Grunwald, anesthetist from the US, and Dr. Chris Scott, pediatric rheumatologist from South Africa. They are returning to the FOP community stage, and you may know these three speakers as members of the International Clinical Council on FOP. They are joined today by Dr. Janieke Van Nugteren, anesthetist from South Africa. Thank you to the four of us for joining today's panel discussion about coordinating care for a surgical procedure. And today's discussion will be focusing on the case of a young man from South Africa. To provide some background context, I'll turn it over to Dr. Chris Scott.
Thanks very much, Hope. It's great to be able to speak to you and to share our experience and to show everyone what this amazing team of doctors from all over the world have done. South Africa is a very large country. To those of you who don't know it, it's obviously at the southern tip of Africa. We have 60 million people, and we have major urban areas and some areas that are very rural and very far from expert care of any sort. And the story that you're about to see will show you some of these areas. So this particular story starts in a place called the Karoo in South Africa, which is really out of the way, shall we say. It's a needle in a haystack, and it's extremely rural, a little agricultural village in literally the middle of nowhere. So without much further ado, I'll start playing this video.
Their search for people with FOP takes the Tin Soldiers team to the unlikeliest of places.
If you were to picture a haystack and picture the bit that you'd never get to, this is that piece.
Dr. Scott and the team believe that in this tiny town, they may have discovered the first multi-generational family with FOP known on the African continent.
Finding them here, it's a bit like a miracle. How does that even happen? So it's a very exciting day.
Dan maak ek nou maar so my shots en dan skiet ek maar net.
Iets van jou postuur werk daarvoor.
A former professional pool player, 24-year-old Rian, is full of surprises.
Dis moeilik, maar dis vir my eintlik lekker. Om vir die mense te wys, ja, ek lyk nie normaal nie, maar ek is baie slimmer as wat enige iemand dink ek is. Ek kan baie meer met my hande doen as party ander mense. En ek kan nie heeltemal reg hê.
Rian's can-do attitude belies the fact that he has lost much of his ability to move to FOP.
Enkels maak vir my so. Hulle is redelijk vast, nee.
Ja.
Ek sien jou hande, jy werk met jou hande.
Ja.
His place of work? A mechanics and engineering workshop, where Rian holds his own alongside his brother Herky and the other mechanics.
Ek verstom hulle elke dag want ek doen elke dag iets nuuts wat hulle nie geweet het ek sal kan doen nie.
Ek het nou self al gaan navorsing doen oor die siekte en waar ander mense is en waar Rian is amazing.
Elke dag. Ek is so trots op hom.
Ons het nie van ek gaan oor 2 jaar nie meer kan loop nie. Ons het nie daai. Ons praat nie daaroor nie. Ons het gewone verhouding.
Rian was himself diagnosed with FOP when he was about 9 years old.
Dit was maar van kleins af wat ons gedink het as iets fout met hom.
Toe het ons baie dokters gaan sien reg oor Suid-Afrika.
Toe hy gediagnoseer is, toe is dit nou 'n ander storie.
Having been given no hope and nothing in the way of medical support, Rian's parents protected him from the details of a devastating diagnosis.
So dat alles weghou van my af. En ek wou nie gehad het ek moet weet van dit nie.
Isolated and losing mobility, Rian eventually turned to the internet in an attempt to understand what was happening to his body.
Ek het eventually op het afgekom toe ek my ma gevra, is dit? Toe sê sy vir my, ja, dit is dit.
And what was that conversation with your mother?
Dit was maar moeilik vir haar.
So druk jy die kos in en dan om.
Hierso, ek trek dit net so hier in. Dis hoekom hierdie tand so gebreek is.
With most of his teeth decaying, his gums inflamed, and the ability to open his mouth only 3 millimeters wide, the simple act of eating is a daily challenge.
Dis moeilik, ek sukkel, maar ek kom reg op 'n manier.
For Rian to undergo any kind of dental work carries the risk of trauma and flare-ups, which could make his condition worse. It's a case for global FOP dental expert Dr. Clive Friedman, on the line from Canada.
He's quite worried about his teeth.
Because you sent me, no wonder he's worried.
Yes, exactly.
Chris sent me pictures of your teeth, and I can see that they're all very bad.
Daar's nie een tand wat reg is nie, almal is stukkend.
2 options are both extreme options. The one is to leave his teeth as they are, but that then one runs the risk of additional flare-ups in the mouth and neck area from chronic infection of the teeth.
It might not be a bad idea, especially in terms of your long-term health, from the perspective of FOP, to actually have all of them removed.
Okay.
Other option is to take out all his teeth, but that is far from a straightforward procedure.
The general anesthetic is a complex process.
He'll need the involvement of a team of specialist anesthetists. And so it's a massive undertaking.
Is there any chance that I could die from it?
I'm not going to lie, the answer is yes.
Dit het my bang gemaak, baie bang.
This is not going to the dentist to have a tooth pulled.
Maar ek het daaroor gaan dink en naderhand het dit vir my gevoel dit is vir my beter om dit te doen as om dit nie te doen nie.
That decision sets in motion preparations for the first surgery of its kind on the African continent, involving a multidisciplinary medical team from Cape Town.
And in him, we can't open the mouth, so we have to do an awake fibre optic intubation.
In conversation with their expert FOP colleagues from across the globe.
I recall one patient actually that had complete dentectomy.
He's got bony fusion.
What was the challenge? How to access the teeth?
Put like a 4x4 gauze into the mouth through that access area.
He was able to get in and do a relatively atraumatic extraction.
One more question.
There is a possibility of bone remodeling.
The risk here is the response of the tooth-bearing bone.
If, say, for instance, we cannot intubate them, do we bail out?
Patient safety trumps everything.
It's the big week of Rian's surgical procedure to fix his dental work. It's a little bit of a touch and go because we're in the middle of a massive COVID-19 third wave scenario. He will consult today with the clinicians who will then make a decision about whether they go ahead with the procedure this week or not. yeah, we'll see how things work out.
Vanoggend moet ons die dokter gaan sien wat gaan kyk na my tande en kyk wat kan hulle doen en wat gaan hulle doen. Hopelik dan is dit goeie nuus dat hulle dit kan regmaak vir my.
It's lockdown, and really this is not at the moment an urgent procedure. The issue also is that we're cutting our list down in theatre. So we've had to kind of prioritize him.
After days of consultations and medical examinations, the clinicians make their decision.
Hulle het gesê daar's nie twyfel nie, hulle gaan voortgaan met die operasie.
Before dawn, on a rainy Cape Town morning, Rian prepares for surgery, as does the multidisciplinary medical team. Maxillofacial surgeons, a team of anaesthetists, as well as ENT specialists on standby in the event that an emergency tracheostomy becomes necessary.
The intention is obviously not to need to tracheotomy, to rather bail if we do.
COVID restrictions prevent the camera crew from entering theatre, so the doctors are equipped with cameras, and the Tin Soldiers team, along with international clinicians, can link in via Zoom.
Our airway was tricky in the beginning, but we're able to tube the patients fairly easily once we're beyond the nose. Sitting here, so we need gently, hold on. I'm going to come there.
Okay, so the latest is the intubation has been completed and it was successful. So now is when Dr. Hine begins with the extraction of Rian's teeth.
He says he likes spicy food, but I think it's going to be like a spicy soup. Okay, we'll just stop it.
So it's been just about 2 hours since the actual extraction of Rian's teeth began. That is now complete. And the extubation, which is again when the anaesthetists get involved, has begun.
Al jou tande is uit. Jy kan nou lekker spicy soup drink. So it went well and it went according to plan. I think we prepared really well for the case. Ready? 1, 2, 3.
Hello, Dave.
Hello, how are you?
Fine, and you?
Good. I just wanted to let you know that they've done the extractions, but it's gone very well. It's gone very, very well. Yeah.
Thank you, Dave.
This is very exciting because the FOP model has shown us the power of this method of working and the power of connecting with people on an emotional level rather than just an intellectual, ethereal, scientific level. By the telling of that story, the potential impact magnifies 1,000-fold.
Massive undertaking and unique circumstances in South Africa required a lot of collaboration, but we all understand that surgery for any individual with FOP, regardless of where you live, will still require a large level of collaboration. So here with me today to discuss more of that experience, what that collaboration looked like, are 4 of the doctors involved in that case. And we are going to walk through some of the different stages of the process to prepare. And we're going to start with preoperative care. So to our group of panelists, what are the first steps that a patient should take when they're aware or when they're considering the need for surgery?
So I'll start this off, Hope. Thank you. Each time I actually watch that movie, I get goosebumps. The importance of, I'm getting some feedback, sorry. The importance of the first diagnosis and then the ability to develop preoperative assessments, I think because of the shrinking global community via internet, it really enables individuals from anywhere in the world, including places that are inaccessible, like Chris was saying, that are needles in a haystack, to actually begin to access members of the ICC, members who have done a lot of this work. And so developing a team approach from a global perspective and educating individuals on the ground becomes much, much easier. So to the first steps in assembling those teams, there are certain principles that one needs to look at, and Dr. Grunwald will take us through that.
Okay, so the first is finding the person who will run the care, who will be the team leader. It's very important. And it doesn't matter if the care is dental, gynecologic, surgical, and so on. Number two is educating the medical team about the disease. It's so rare and very unusually that someone on the medical team will know about FOP. So leading the process and opening the mind and letting the team asking the questions. The third step, connecting the team with the experts. So usually I receive a phone call from somewhere on the globe and they present a problem. Sometimes they call Clive or Dr. Kaplan, which is well known in a community. And then we assemble a meeting of the patient, the caregivers, the family, the specific surgeon that deal with the problem was presented to him. Oral maxillofacial surgeon, dentist, gynecologist, surgeon, general surgeon, and so on. So as you can see on this slide, this is a typical team that we assembled at Jefferson. So we say special team deserves special patient deserves special care. The FOP patient is in the center, and at Thomas Jefferson University Hospital in Philadelphia, you can see the various experts that actually assembled to care for the patient. Over the years, we've done this process more than 150 times, rare commodity, but it allows one of these experts develop their own know-how, how to deal, and then we update the community in the world. What have we learned with each encounter? And as you can see here in the slide, communication is the key. We talk a lot among ourselves, and of course with a team wherever it is set in the world. And you can see, for example, this is a dental procedure. So we have an ENT surgeon or oral maxillofacial surgeon, even a medical student. We bring them because they should be the new ambassadors in a new world and spread the know-how and the knowledge among the peers. Everyone that exists, and usually in my operating room, we have many medical students, residents, and fellows that later on they go finish their education and spread the message across the country or the globe. From the surgical point, from the anesthetic point, is very important to make sure that the person who is doing the anesthesia is familiar with nasal fiber optic intubation, which means looking through the nose into the airway and identify the passages that we can insert the breathing tube in order to secure the airway. If it's not stated earlier, patient safety trumps everything. Patient comes in usually from home, safe. He or she should leave home safe and untouched. And the margin for error in this patient, because of the physiologic backup, is so sometimes slim. We have to make sure that the anesthesiologist and his team have done, and if not, we ask to move the patient to a facility where the anesthesia team have done and master the nasal fiber optic intubation. And usually it's an academic medical center, but not necessarily. Sometimes even peripheral hospital have the anesthesiologist may know and may have the expertise. And it's not only securing the insertion of the tube, but how you actually extubate the trachea safely and crossing on this fine bridge without harming the patient. It can happen, as I mentioned, only when we build a team and there is a commitment by the institution to provide the resources for the team to excel. The patient needs unique handling and care in the area that they sit in the hospital, on the operating room table because of the immobility. So it's a whole different story that we talk offline with the anesthesia team and the perioperative team to pad the patient and make him or her comfortable during the procedure. I'll stop here, and if you have any other question, happy to answer. Oh, here is another slide, which is very, very important. We talk about rehabilitation of after surgery. Extremely important to build stamina, physiologic stamina at the patient before the surgery happens, especially if it's a non-urgent surgery like dental surgery. So the patient we encourage them to do and support the respiratory care, do as you can see here, incentive spirometry makes the lung stronger. And I tell the patient, going to the surgery is unique in every patient's life, no question for the FOP patient. It's your day in the Olympic. And in order to succeed, you have to be the Olympic champion. And like Olympic champion, prepare yourself. So we encourage them to walk, we encourage them to talk, we encourage them to do the incentive spirometry in order to build respiratory reserve and stamina. And as I mentioned before, special arrangements need to be done on the waiting area, operating room, and recovery that meet the specific needs of the patient. Usually, when the patient goes to the surgery, the family stays behind. We encourage the team that the family or the caregiver stay with the patient. Sometimes we bring them to the operating room to provide comfort and be in the operating room even before the breathing tube come out so they can communicate and advise the patient, hold the hand, and of course, going to recovery because they have seen the patient and they can advise the nursing team in recovery room what really is the urgent needs of the patient and communicate and help both sides, the patient and the care team.
So here's now an opportunity for both Janieke and Chris to talk about how that team was assessed and developed in South Africa, where this procedure had not been done before. So Chris, Janieke, I'm going to let you go ahead.
I guess I'll start because I was sort of part of putting the whole team together. It all started with us meeting the patients, as you saw in the video. We went to the town and assessed Rian, and then assessed what his needs would be, and actually discussed with Dr. Friedman whether or not he would need surgery. So we started first deciding what the surgery that was required, and in this case, Rian needed all his teeth withdrawn. And we then, of course, realized that it would have to be an inpatient hospital surgery procedure. And so we knew we'd need at least an anesthetist. But we also, of course, they needed to find a surgeon. And so we're lucky to have Dr. Van Nugteren as our FOP anesthetist who's done procedures on FOP patients before. And so we reached out to her and to the local dentist and to find a maxillofacial surgeon who would be able to take this on. It's important when you put together a team like this that it requires people to be very open to new ideas and also be very open to completely non-hierarchical collaboration. There's no place in this team for people who are not prepared to listen to other people on the team. It's a real team effort, and the role of the team coordinator is really just coordination. Anyway, so we found our maxillofacial team and then moved forward. Of course, we also had to have a logistic team which included the IFFP, FOPA, and so on to find the resources to be able to travel with the patient. We required the team from Tin Soldiers to do the on-the-ground patient support and communicating with the patient to talk to him and his family and to make the logistic arrangements for them to come to Cape Town. And Janieke, I wonder if you want to take over and talk about how you assembled the various surgical teams in Cape Town as well as the anesthetic team, because it wasn't just one anesthetist again. We needed teams within the teams.
Yes, thanks, Chris. So I think what was quite fortuitous was that I happened to do a maxillofacialist most Monday mornings, and with this maxillofacial surgeon. So it kind of helped that I had quite a lot of experience doing maxillofacial anesthesia, and the surgeon was willing and keen to do it. So Odette put us in touch with the patient, and he came to the clinic where he was assessed by Dr. Hine, the maxillofacial surgeon. And then he said, yes, he'd be prepared to do the case. And then obviously from an anesthesia point of view, and he came to see me, and I used to run a pain clinic. So the patient came to see me in the clinic, and I was able to do a thorough preoperative assessment. And I think one of the biggest things that I learned, since this is the second patient with FOP that I've anesthetized, is listen to experts. You can read as many articles as you want, but you need, and since having seen many patients with FOP in Sao Paulo, is that you really need to understand that the anesthetist can never, like you say, you need to listen to what other people advise you and tell you to do. I think the first case that I did, Zvi told me strongly don't put anything in the mouth if you can avoid it, because I was planning to put in a laryngeal mask because the child had very good mouth opening and just extremely how could one say it? Strong recommendations: do not open the mouth. You're not going to go in the mouth. You're going to do a nasal intubation for the boy that we did previously. So I think having read around it is never the same as actually talking to people and being given that sort of that advice of somebody who's done it so many times to say, let me tell you, just don't do this, because it's very different to you reading about the condition. So I think that really helped me. And I think for myself, having seen so many patients with an understanding the implication, I was able to teach the team that I was with. So I got a registrar who was particularly keen in helping me with the case, and a whole lot of sort of other people in my department who were willing to be present if we needed extra help. And I think because I've been overseas and spoken to my department about this, I think everyone kind of got quite excited about the fact that we were able to help somebody with FOP. And since Ren, this was a big case. So yeah, I think we were very lucky in that we all happened to have worked in this area before and had an idea of what to do. And despite the fact that it was in the middle of the pandemic, we were able to coordinate things fairly well.
I can just add, once things were actually in theatre, we still needed to involve other teams. As the day approached, we needed the ENT surgeons to be on standby. That's something that the theatre was packed with people in the end, because we had a whole ENT team standing by should the fiber optic intubation fail, so that they could create an alternative airway for the patient by doing a tracheostomy. So we needed to think on our feet a lot of the time, yeah.
Yes, exactly. And I think what happened there was that perhaps the communication wasn't as clear and as laid out and in the correct channels as what it should be. In other words, we told the ENTs that we would potentially be needing them, and then the message was filtered down to a fairly junior resident or registrar, as we call them in South Africa, who then kind of arrived there and was very excitable and immediately wanted to potentially slash, go into the neck. And I had to tell her in this moment that this is now not the thing we're going to be doing, and we're really going to be avoiding it. And the volume button just needed to be turned down significantly, since this was a case that many of us had been discussing for months and months and months. So yeah, so those little things you have to, at that moment, manage accordingly, but they have the potential to create quite a lot of havoc if the community. So our learning lesson from that is I think that our communication, because I think we were trying to coordinate so many things, and it was the one thing that we just hadn't, made absolutely sure that they were ready and everyone was on the same page. So yes, every single team member needs to be informed, and every single team member needs to understand exactly what's going to be done.
And let me just make a comment. What you see here, and I'm talking to the audience, is exactly one of the major takeaway lessons. In today's world of rush mentality, I'll see you in the morning of surgery, we'll take care of you. Absolutely, this is not the case. And if you heard, the word was preparing for months. Well, they had the luxury of time, access. But even if not, an anesthesiologist, especially the anesthesia team, needs to meet with the patient at least 1 or 2 days ahead of time in order to see, to prepare, realize the magnitude of the challenging of accessing the airway. And what in anesthesia we always ask, if something goes wrong, what is plan A, plan B, up to plan Z? And do you have the resources to each one of the field? That's why it's a specialty that leads the safety in medicine, like in aviation. Safety trumps everything. So as you can see here, imagine that the patient will show up to the day of surgery without everything assembled, confusion and life-threatening situation. So that's one of the major takeaway. Take your time, familiar yourself, and like Chris was here, the team leader, lucky if you have someone who is not only the team leader, but knows about the disease. And most of the time, 99% of the time, there are no Chris's, no Janike's, the team that actually a little bit agitated from the task. And when we put them together, rather than sending them to Jefferson with all the inconvenience, we trying to build at least one team of experts in each continent that they gain the expertise and advise and learn from every case that they are doing.
I think that the other thing that I'd like to highlight here, Zvi, Chris, Janieke, is the importance of a team champion. And by team champion, I mean an individual. In the case of South Africa, Odette from Tin Soldiers was that champion. She was able to navigate the whole system and to figure out where to go, how to go, and what resources that one can do. And oftentimes, this does not have to be a doctor. It does not have to be a professional. It can be anybody who has the best interest of the person in their mind. And whether it is the United States, Canada, South Africa, it does not really matter. But I think that having someone who can advocate and help you move through the systems, and various countries have very different systems and very different challenges that present. And so having someone who has that ability to help navigate that, I think is key to long-term success.
I couldn't agree more, Clive. It is really essential, that team champion who is the person who gets communication from everybody all the time, and is the one person who's keeping an eye on all the moving parts of this, both on the social side, i.e. On the patient side, the logistics side, and also is able to create bonds with all the people in the medical team. So in our setup, that involved using something that perhaps is not very familiar to North American audiences, but we use in South Africa something called WhatsApp, where it's very easy to create groups and to communicate in large groups with one another. And to have someone set that up and run that and then be the go-to person for everybody's problems is absolutely essential. And Odette did and the whole Tin Soldiers team did a fantastic job on that, I must say.
So then we move to the actual intraoperative procedure that you have heard some about, but I think that it would be useful to have both Janieke and Zvi talk about their plan for contingencies and what happens if surgery is not always predictable.
So Janieke, why not you tell us what happened or what your experience from the intra-op experience in your case? And now you are the world champion, actually the African champion, mastering 2 cases of FOP more than anyone else on the continent.
I'm not sure about that. We have to check. I think in Johannesburg, there may be one guy. I'm not sure. I think he's only done one. But yeah, so we were going to do an awake fiber optic intubation for him. So obviously that required preparation with all the necessary equipment to make sure that our equipment was working, to make sure that we're all familiar with the equipment. And then in particular, getting the right level of sedation and what drugs to use for that. So we were lucky enough, in South Africa, in the state, we have access to dexmedetomidine, or Precedex as it's known. So we were able to use that as a sedation. One of the sort of tricks of the drug is that it takes time to get a decent sedation, level of sedation. And if people are hurried and people are rushed, then you're going to get yourself into trouble. So you just need to be as patient as you need to. And then we obviously nebulized him, which is quite difficult to do since he couldn't open his mouth. So we used local anesthesia in the form of gel and swabs and gauzes into his nose. And then we nebulized a lidocaine or lignocaine, as we call it in South Africa, together with the dexmedetomidine. And then we just waited. The dexmedetomidine wasn't necessarily enough. We still needed to give small boluses of remifentanil towards at certain points during the intubation. But I think he tolerated it fairly well. And technically, once we got through the nose, there really wasn't any difficulty in getting in through the vocal cords and through the larynx. And he ventilated with ease. There were no issues. I mean, his chest X-ray did show significant restriction, and his lung functions were significantly restricted. But we didn't have any problems with that intraoperatively. And post-operatively, he went to high care and was eating lamb soup the next morning, which I prepared with lentils. I thought that would be something. He hadn't eaten anything sort of hearty for days, and it was a nice thing to try. I don't think it was the best lamb soup though, but yeah. So we didn't have any issues in analgesics. We gave prednisone pre-operatively as well, and I think our analgesic regime worked quite nicely for him, and he did very well.
So another comment that I would make, it's like in aviation. Pilots, in order to stay active on the duty, every 6 months go to a simulator and train what-if situations. Something happening for the team that go and will take care of the FOP patient. Usually on an offline discussion, you heard me telling me offline, we talk to the anesthesia team, we simulate the operating room step by step. What do you do? Talking to the anesthesiologist and sharing with them the experience that we have at Jefferson. So all the things that Janieke had told us that she has done, we actually simulated verbally step by step. So she is kind now second time or third time in a situation, which helps you to realize when it's going well, if it's not going well, what's actually the contingencies and the options. Intraoperatively, we found out that because of the intractable pain, we have seen patients that has opioids, narcotics, patches, so they're continuously carrying them. It resets the whole response to pain to totally different level. So the usual doses of medication will not be enough. And when the patient falls asleep and surgery proceeds, we see that the heart rate traces up to very, very high levels. Experience showed us, and this is specific just to share you, how much the knowledge has advanced we found that if we start an infusion of a drug called ketamine, all the things go down, patient comes down, and for the surgeon, those around, they will see nothing. But we watch the monitors and the heartbeat and the respiratory and oxygenation and other parameters. We can see and follow the patient literally beat by beat with his physiologic responses to bring them down to a comfortable level.
So I'll keep us moving. I think you have all done an amazing job of covering the what happens before the surgery and then what's going on in the midst of the surgery to keep everyone on the same page and to keep the individual with FOP safe. And now I think we're ready to kind of transition to after surgery. So how does this system, this collaboration that you've all spoken to, continue to operate optimally after a surgery is over? And recovery is a big part of that. So how do you continue this quality of care for the individual with FOP?
Janieke, what happened in your case?
Yeah, so I think, as usual with most post-operative, people start patting themselves in the back and just happy that everything has gone well, but that's when people start dropping balls. So making sure that, like, for example, his prednisone post-operatively was actually prescribed and given. In his case, he needed to catch a flight the next day and then didn't have time to go to the pharmacy and didn't get the meds. And then fortunately, we were able to communicate via WhatsApp and I was able to send him a prescription to get it. But it's those kinds of things that I thought it's very easy to just now, lose track of what has happened. So the care in the post-op period continues. And I know that he communicated a few weeks later also saying that he had some swelling in his mouth, Chris, and I think that was probably just likely to be due to the post-surgical, but didn't look like it was actually a flare. So those things are, we need to bear in mind that you don't just wake the patient up and it's over, but it does involve post-op care and people need to look and coordinate that. And I think in the case, once again, Odette was instrumental in helping us with that too.
Yeah,
I know there was discussion.
I apologize.
No, I was just going to say, I know there was discussion of a follow-up plan with clear terms of who should be contacted if different scenarios or situations were in play.
Yes, that's right. In the immediate post-operative period, Janieke and the anesthetic team were the immediate and the surgical team were there for immediate concerns or complications. And then once it was clear that the anesthetic period had passed and the healing had started taking place, there were some issues that required ongoing engagement. Fortunately, our WhatsApp group stayed intact, and the team communicated, or the patient communicated with Odette, and through that we've communicated with Clive and to monitor some of the post-op symptoms. Some of which we thought were just related to the bone healing up, but there were also, especially in the case of FOP, it's always essential to consider that a flare of ossification might happen somewhere in the operative area or somewhere where an IV line might have been inserted or something like that. So it is important to keep in touch and monitor for those flare-ups. Clive, I don't know if you want to comment on the dental part of the follow-up.
So before I comment on that, I do have a question because I was asked this by a patient just yesterday. Post-surgery, what is the expectation with respect to how long you can expect a flare to occur because of the surgical procedure? Would it be 1-2 weeks? Could it be months? When would you expect a flare to occur directly related to the surgery?
So, excellent question. And we're always aware that we warn the FOP patient, try not to get to trouble, not fall, not to have any trauma, because it can precipitate a flare-up. And here we are inducing a trauma. The answer is time-wise. years ago, there was a 12-year-old girl in Philadelphia neighborhood area riding her bike, fell, hit the head on a curb. She had epidural hematoma, rushed to the hospital. They saved her life. Evacuated the hematoma. She went home. Everything was fine. 3 months later, her jaw locked for life. Why? Because anesthesiologist in part of the emergency had to put a breathing tube and did what we call direct laryngoscopy. It's opening the mouth wide in order to insert the tube. It triggered inflammation response on a temporomandibular joint, and the patient shut her mouth for life as a response. We learned the lesson. That's why we recommend never, ever do direct laryngoscopy, and it can take up to 3 months before we see the full effect. That's why we do the much more complex nasal fiber optic intubation. Knock on wood, or just knock on wood rather than on my head, we give steroids. And in the many, many dozen cases that at least we have seen at Jefferson, I'm not aware of a single patient who had flare-up, but we were very religious administering steroid from even before the surgery starts or immediately after the intubation throughout for at least 3 days post-operatively. So time can lack for about a couple of weeks. My personal experience, N of 1, we have seen one patient, but it tells us that it's definitely not 0. Another thing that just go a little bit higher from ground level to 20,000 feet, 30,000 feet, and see patients that come with much more complex surgeries. So expanding a little bit the scope of this discussion. Just recently, we had a patient that fell and broke his neck. Very complex and serious injury. We call it C-spine, cervical spine fracture. It's an emergency. So he was brought to a neighborhood hospital. They had no clue about FOP, but they're ready to go for surgery. So we have to move the patient and a lot of administrative challenges on the way to Jefferson Hospital for Neurosciences. We have a very unique hospital among the few that's what they do. A patient with a disease of the neurological system and the neurospine area. And the patient also, because of the fall, had a fracture of the leg. So here now you have a patient with FOP, multiple surgical challenges, a lot of pain, a lot of discomfort, needed surgery now. So the assembling of the team, calling into action not only Jefferson, we called in Mona El-Mukadam and Dr. Kaplan. So we expanded the scope of team of experts to inter-institutional just to make sure that the best team can advise and provide care. The patient had surgery, did well, but needed a whole slew of other procedures from different teams, physical therapy, and other teams that, again, didn't know much. Eventually, he moved to recovered more, moved to a recovery hospital. And again, you have to present the challenge to a whole new team. So as you can see, recovery can last rather than, I'm going home next day, weeks or sometimes months. And all this time, someone has to be there watching, explaining, educating the new team members. And when they see the care, they embrace it and of course, take it to the next level. So just to say, it's a story that you read with many listeners and many individuals eventually comprise what we call the care team that can be more than just 2 or 3 specialties.
And so it's important to follow up with primary care providers and to, again, have that champion that can help advocate for you as a global team. I can't emphasize enough the importance of the champion and of your primary care provider who can help with that follow-up. A lot of times, just because you've had the surgery should not mean that, I can I'm now okay, and I can let everything go by the wayside until the next crisis. You really want to engage your professional as soon as possible. So what did we, some of the learnings or guidelines that we look at from at least a dental perspective. I think we came up with these, what I call the 10 commandments of care. And as Zvi has already identified, safety trumps everything. It's above all. But the thing that is perhaps most important is that we don't want to end up in the circumstance where you have to have surgery. And so you want to manage your risk of developing the problem in the first place. So from a very early age, it's really important. And so what the Tin Soldiers team is looking at doing is identifying and diagnosing FOP from as young an age as possible so that we can help minimize the risk of needing any kind of surgical procedure, of getting in to do any kind of intervention. So implementation of daily good practices is absolutely essential. Brushing, cleaning, hydration, nutrition, all of these are absolutely essential. Dr. Grunwald discussed with you the importance of lung health, breathing, swimming, singing, maintaining very good lung health is essential. If we have to do an intervention, if possible, we want to try and do that intervention not under general anesthetic and maintaining good anatomical position and not doing, as Zvi spoke about, oral intubation where you're keeping the mouth really wide open and triggering a problem because of overuse. For any dental procedure, I think it's really important that you have oxygen saturation that you evaluate every time you actually go for an appointment. You have the maximum mouth opening that you have and always treat with the mouth open less than the maximum that is possible. So taking care of mobility restrictions where you give the individual cushions or support that makes them as comfortable as possible. So we want to minimize the triggers of FOP as much as possible. And many of you are very familiar with these triggers: trauma, stress, muscle fatigue. You're very well familiar with the complete contraindication with any kind of intramuscular injection. And a lot of oral practitioners perhaps are not aware of this, and this is where it's important that you become self-advocates. And then it's essential to follow up when you have complex procedures with prednisone. Did any of you want to add to any of these issues that I've just identified?
Definitely, I would like to. So, 2 lessons learned from this and other encounter that we had. Number 1, I'll start with the more specific. As Dr. Friedman said, you don't inject or use needles intramuscles. However, and that's combined with the other lesson learned, there is hope. Every year, we encourage and we dare to go to uncharted roads in a field of interventional medicine. It was inconceivable that an FOP patient will have major surgery, and we're starting to know how to allow patients to undergo major surgery, or even to areas that we will advise them not to go. So let's start with the hope. 2 young ladies wanted to become mothers. So usually pregnancy may involve emergencies, severe bleeding, and so on, that may necessitate surgical intervention. So if you live not in a rural area that fancy medicine is not immediately accessible, you may be endangering yourself and the baby. Even who will do nasal fiber optic intubation at 4 a.m. in the morning during an emergency, and is there is a team to do it, in a remote area. But in the last 2 years, 2 young ladies became pregnant and underwent cesarean section by a team of experts with nasal fibroctor intubation. Now they're holding 2 healthy babies. Happy situation. Another thing that we learned, we had 2 young ladies that had hysterectomy for various reasons. Big surgery removing the uterus. It's major surgery. In order to help them get out of bed and ambulate early, we have to deal with pain management. So like you go to the dentist and inject local, so the pain of extraction and after the mini surgery is taken care of. We have inserted under ultrasound guidance special blocks into the abdominal wall to numb the muscles so the pain of surgery will be significantly taken care of. And each one of these young individuals, either on the same day or early next morning, stepped out of bed and did few steps, which was very important for recovery. So as much as we say in order to put the blocks, you have to go with needles and to special places in the abdominal area, but we gave steroids, there was no any flare-up, and everybody, including the patient, benefited from both advanced knowledge procedures.
Chris, I think you had something to add.
Yes, my comment was really around the preventative care, which I wanted to stress again. I think, having a diagnosis of FOP when you're young is great, but what's essential is actually that you stay involved and attend follow-ups so that you can head off trouble. It's not enough, really. I think a lot of people get the impression once they're diagnosed with FOP that doctors have told them there's not much we can do or there's no treatment. And then they fall into the mistaken idea that there's nothing that can be done. Meaning there's no treatment doesn't mean that there's nothing that can be done. All of these preventative things can really be optimized to try and push out all of these complications as far as possible and to minimize the risks as far as possible going into the future. So the point of an early diagnosis is to institute early preventative management. So I just wanted to re-emphasize that point. And that's why I think the work that Int'l is doing is very important, because it's not just about the diagnosis, it's about creating a pathway of care and regular follow-up.
Here's a slide that actually captures our early experience at Thomas Jefferson University. We have seen that in a patient that have had surgeries in other parts of the world, sometimes they've been kept in a hospital after minimal procedure for a couple of days or sometime a week. So we looked at our experience and we published a paper in the journal Anesthesia or Analgesia, which I provide to every team that we connect with. Now we have a few other papers that we share experience with other cases. These are patients coming from dental procedures. So you can see over a spread of 10 years, 30 patients underwent 42 procedures. And you can see here that many of the patients were actually pediatric patients. Almost 90% of the patients were discharged home the same day. But let me be accurate. Sometimes they stayed in town just another night to make sure that everybody's comfortable and recovery is still really moving on as expected. But we kept about 14% for overnight stay just because other comorbidities, asthma, managing diabetes, and other medical issues. But overall, 100% of all these patients, the outcome was excellent. No one had flare-up, and all of them went home and continue with excellent, usual life after the procedure.
Zvi, there was a question I think that's useful to answer at this point for either you or for Janieke is, are you, both of you, comfortable with the use of nitrous oxide sedation where you're not using a general anesthetic for axial-lysis, for decreasing anxiety in individuals, to do treatment on an outpatient basis? What's your feeling with respect to the use of nitrous oxide? I know, Zvi, that we've had this discussion, and I think it's important to perhaps speak to it.
The risk, of course, that the patient with nitrous oxide will lose some protective reflexes. The worst that can happen is a patient become a little bit sleepy, and if he or she ate something, they may regurgitate content from the stomach, aspirate to the lung, and then they will be really in life-threatening situation. So that's risk number one. And the other risk is when you sedate the patient, sometimes they stop breathing. Highly unlikely, but you cannot, it's never zero. And what do you do is a patient actually, let's start with one step backward. Many of these patients, their physiologic reserve is significantly less what we perceive it is. So the difference between not breathing, slow breathing to no breathing to asphyxia, sometimes it comes very fast. And if the system is not built to manage it, then the patient may be prone to disastrous outcome. So it can be given cautiously. I never gave it because I felt that if there is a need to provide some kind of significant pain management, you secure the airway with all the risks, and you heard from Janieke. Oh, after we place a breathing tube, nothing happened. You secure the airway, and then you have all the time in the world the surgeon can do and concentrate on what they want to do. So, like anything else, every medication has side effects, and definitely with patient with FOP with so limited physiologic reserve, especially in the respiratory part, you open yourself to a risk. I don't want to dramatize the situation. We have few anecdotal cases, like a child who was taken care in a private clinic, and the anesthetist tried to do general anesthesia, but didn't realize that he will not be able to put the breathing tube in place because the jaw was relatively immobile, the neck was immobile, and on and on. So it's not only that it's not a regular patient that you can use regular modalities to save the airways, it always will be very, very difficult and close to impossible. So all of the things needs to be taken to serious consideration. And that's why we encourage the patient and the care team to communicate among ourselves, ask us questions. And yesterday we were in a major safety session at Jefferson, and the world guru in simulation stated, in many cases, the disaster happened because a question was not asked. So if you have not dealt with patients with FOP earlier, please connect with the expert, ask a question, or they will ask a question, making sure that the safety network is spread wide around every single patient that we provide care in a perioperative situation.
I've seen a few more questions come in that are. Oh,
yeah, I don't.
I saw a question about England. Yes, in England, just recently, this was one of the areas that a young lady needed C-section to delivering the healthy baby, and she was an FOP patient. There was an excellent team of anesthesiologists. What they do is OB anesthesia, obstetric anesthesia. And in England, there is an expert, Richard Keane, and he's the one that orchestrated the whole care. Long before the young mom became pregnant, she came to us in one of the national meetings and expressed a wish to become a mom and helped to carry it through until the very happy moment that the healthy baby was delivered and beyond. Any other questions?
There's one more in here I'm going to ask before we go to the one that Clive has pulled up on the screen. It's regarding an esophagus biopsy through endoscopy. So if a patient was needing that procedure done, is there a recommendation you would make in terms of anesthesia?
Absolutely. This is a situation that the gastroenterologist has to go to the mouth, pass the laryngeal area, trigger or irritate the airway. So I would strongly recommend general anesthesia aided by nasal fiber optic intubation by experienced team. And again, would encourage the anesthesiologist or the anesthetist to talk to us so we can go and discuss the management and recommend to see the patient ahead of time to familiarize herself or himself with the anatomy, the patient, and the physiologic reserve, and ask questions, talk and talk and talk, communicate.
There's a question on the screen, which is one that we identified and we wanted to address to make sure we addressed at some point in this talk. So it was surrounding a situation where a patient has been referred or is seeing a doctor who thinks they know everything they need to know and doesn't want to reach out to FOP experts. So what advice do you have for a patient who's working with a provider in that situation?
We have seen a couple of those surgeons that inappropriately, I wouldn't say rudely, advise the patient, just come to my office and the anesthesiologist will wait for you. That was one. And another one in an ENT surgeon that said, oh, I give my own anesthetic, God forbid. So he's also the anesthesiologist, anesthetist, and the surgeon. So we strongly advise the parents to move away and seek another person in an institution that can provide safe surgery and safe anesthesia and have a team working around and managing the care of the patient. The other question, how to find the right surgeon? Again, communication. And I'm sure that in every country, in every area, you can find, if you talk to the individual expert in a country or in the continent, they can advise, and we talk a lot among ourselves, the expert in FOP, and we communicate and share information. Years ago, there was a young girl, 10 years old, with emergency in her abdomen. The surgeon called me, and we realized together that actually the patient needs to move up 2 levels of care. It was in the middle of the Andes Mountains in South America, to a university-based medical center, and the child was taken care of. This was done. Probably now she is doing well, and she's in mid-20s. So communication.
So I might add here, Hope, that I think this is where, again, having a champion and an advocate is really essential. And I'll give you a really good example of how that could work. I had an individual who was very concerned about the care that her child was getting, and she was from Turkey. And what she did is she took her child to the dentist, and she actually had me on WhatsApp and didn't allow the doctor to actually look at the child until he spoke to me on WhatsApp right in the surgery. So if that was not going to happen, she probably would have walked out. So I think the importance of communication, as Zvi is talking to, is essential, but also the people who know their problem the most are the individuals with FOP and their parents. And we need to learn to listen to them. And if we don't listen, then my recommendation would be to find someone who does. Chris, Janieke, I'm not sure what you think.
No, I want to agree completely with you, Clive, and I want to emphasize the fact that you as the patient has the right. Your rights are the only consideration really in this whole thing. So you have to develop the agency and the confidence to be able to tell the doctor that you will not accept their care anymore if you feel that they're not able to communicate. That always for me is just a bad sign in general. If a doctor is absolutely refusing to talk to a colleague, that's generally for me quite a bad sign. Most of us are open-minded scientists, scientifically thinking people who are keen to engage and learn and develop networks. And if people are behaving in a way that it's different to that, it should raise some alarm bells. I don't know, Janieke, if you want to, you've probably got the most experience with surgeons. Maybe you want to say something.
No, I agree. And I think particularly for patients who don't have the inside knowledge necessarily of knowing what type of surgeon he is, or what he does, or what he says he does, is always quite difficult. But I absolutely agree with you. If you have somebody who, obviously many of them have egos and don't want to be told how to do things, but if you're feeling that this person is not open to even, like you say, communicate to experts in the field, then I would, and it's often I imagine quite difficult with people of, low socioeconomic means who don't have access to, to care on any level really, then you should try and seek help elsewhere, and ideally through, IFOPA, you'd be able to be put into contact, at least through networks. Somebody will be able to arrange something. But I would say, never fall into the trap of just saying, okay, well, he's the only person, and he is, even though he's being, I'm saying it's a he, even though he or she is being difficult, I should just go with this because this is my only chance. I think that is the potential for a disaster to happen. So you need somebody who's open to collaboration and hearing.
It's so important to hear that message from all four of you, because I know that for a lot of families, it's not an easy step to take. It can be hard to stand up to the white coat syndrome, to someone who is a doctor, who is in sort of a leadership role in your care. And so I just want to acknowledge that it can be a really hard thing for our families to do, but that it is so important. So I hope the encouragement of all four of these doctors will help embolden our families to feel empowered in those situations to speak up if they're working with a doctor who doesn't want to collaborate. But, there was one
time, and as I just said, and most of the time, all the champions like Chris, like Dr. Fred Kaplan, like Mona, like Dr. Keane in England, and others, and we have them in spread around the world, they make themselves available all the time. So they don't, if you send them a communication, they will not ignore it. Always there is an answer, and will guide every single of these patients or families or even experts who call them to guide them to the right appropriate solution or management. And again, we communicate among ourselves just to make sure that eventually the patient gets the best answer, the best care that we can.
And before wrapping up, I wanted to ask one more question that's a little more general, but there was a question in the Q&A about sort of considering different levels of risk associated with surgeries. So are there, I don't know if any of you, I think, could answer this, but are there any specific criteria you look at when you are considering whether or not a specific surgery, when you're considering the risk involved with a specific surgery? I guess from just a very general surgery perspective, what is sort of the deduction or the decision process to deciding whether a surgery is right for someone? Or what would you advise someone who's trying to decide if a surgery is risky or too risky for them?
I don't know. I can give a crack at that, Hope, and then the others can chime in. From my perspective, most individuals are really not very good at assessing risk-benefit ratio. I'll just give the example of COVID vaccinations as an example of the number of individuals who refuse to get vaccinated because of the so-called risk. But they could have more of a risk of getting sick or being hit by a car when they leave their house. So they don't really understand that risk-benefit ratio. So to some degree, we as a professional need to help educate from the FOP perspective. So for me, I am not going to recommend a very complex surgery where you have to do nasotracheal intubation and extractions if the risk of the surgical procedure is going to be more than them having a particular problem from just sitting and doing nothing. And so an example would be wisdom teeth. If we've got a wisdom tooth that is not causing a problem, am I going to recommend that we actually have a surgical procedure to extract that wisdom tooth? I would say I don't recommend going for extraction just because it's maybe impacted. If it is going to cause more of a problem or result in a flare, if it's going to result in a long-term quality of life issues for that individual, then we need to begin to take that into consideration. So it's an individual basis. That's what is important for an individual, what is not important, and we can't make a general statement about it. It's got to be directed to the specific needs of each individual of what they're comfortable with or what they're not comfortable with. I think that you guys probably do this a lot more than I do. So I'm going to let Zvi and Chris and Janieke take over here as well.
I would say that FOP is a spectrum. It's a disease that evolving over time, over age, and everyone has its own road with a different, I would say, how steep is the road? It's very individual, which make it easier or harder to manage life. And along the same road as the individual involvement of the disease, it has a significant say about when you combine it to the need for surgery to make a decision. What is more important at specific setup of time in life and your dance with the disease. So it's much more complex rather than here's a problem, do I have a surgeon or not? Because it's about the patient, about his or her life, about their dependency, what they do, and so on and on. So a 5-year-old, 15-year-old, 25-year-old, 45-year-old can see different angles of life circumstances and then advances of the disease and the specific issues that they have. So for the specific question, we may have different answers. As much as we advised to 2 young ladies after we met with them and sorted out other issues, go ahead and successfully brought them to happy shores and with a pregnancy. On other occasions, we strongly advise the mothers not to go on this route because of the potential life-threatening situation. Same question, different answer, because the patient came from different trajectories along the route of their lifetime.
I might just add to that and just say that in every life is so complicated. It's always complicated. And you might actually end up in a situation where risk and benefit are actually 50-50 or 55-45. And in that situation, you just need to have a sit down and an honest, open discussion with everyone in the same room and make a decision. And it's going to be a balance of everyone's perception of the risk and the benefits, how that argument will end. And you have to have a very honest and very clear conversation. And I'll never forget, in the case of this patient, Rian, I think it was shown in the video, where he directly asked, and could I die during this procedure? And Clive looked him straight in the eye from 10,000 kilometers away and said yes. And that's the kind of honesty that is required so that you can really judge your risk. And I think the patient in this case really, really appreciated that, because if someone had said, "Yeah, no, don't worry about that. That's not a thing," and he didn't trust that comment, then things could have worked out. He might have made a different decision. So I think that honesty and that open discussion, and sometimes there is equipoise between risk and reward, and you just have to have that decision-making meeting as a team.
Another good question just came in. It's asking about surgical tools that are used when a jaw is locked. So I think the heart of the question is someone's wanting to know, if your jaws are locked, do you always have to extract teeth for accessibility, or is it possible for people to keep their teeth intact if they need to have surgery on something in their mouth?
Perhaps I can answer that question, Hope. Again, it again is a risk-benefit ratio. If you've got your jaws locked and you do not have access to eat or to expectorate, to vomit, and I had one patient who would get quite ill sometimes, and she was extremely fearful that she would inhale her, if she vomited, she would inhale it. And so we ended up needing to extract some teeth so she would have a space from which that could come out. So certainly you do not need to take out all the teeth, and you only take out teeth when they are severely diseased, but you can maintain teeth there for many, many years without doing it. But again, it's dependent on your ability to keep those areas clean. Oftentimes the very back molars become impossible to clean, and so they will then deteriorate rapidly, become infected, and then if you've got infection and chronic infection, that can result in a trigger. So it's dependent on the ability of the individual to maintain the mouth, because if they have difficulty, if they've got strictures in their extremities and they cannot brush their teeth, for example, then that could be a problem. So it's again going to be very individualistic about on the needs of each person with respect to their ability to eat, their ability to talk, their ability to drink, and if they're sick, what they need to do. So these are, again, important areas of communicating with your primary healthcare provider as to what is happening. Perhaps Zvi has something that he could add to that.
No, as I said, just an anecdote that really emphasized what you just said. There was a young lady that came to Philadelphia for teeth extraction. She was the first patient that we went to this area years ago, and she came from a remote country. And Dr. Desidua, who is actually the most experienced oral maxillofacial surgeon who did extractions for patients with FOP, did the teeth extraction. I forgot about the case, and then I get a nice Christmas card, and it's about time now. And she said, thank you to the whole team. After so long time, I enjoyed, in Christmas time, a good steak. So sometimes there is positive things that come out with these not happy situations. So and you mentioned different aspects why sometimes you have to do the teeth extraction and what the benefits of the extraction for the patient. So it's not only for bad stuff, sometimes only for good stuff. And don't forget, life still has many good occasions to celebrate.
An excellent note to end on. Unfortunately, we are going to have to wrap up this wonderful session, but I want to end by saying thank you to Tin Soldiers for supplying Rian's film for us to show and share, to highlight a wonderful case study and kind of set the stage for our discussion. And then I also want to say a huge thank you to our 4 panelists today. And I know that there was a very important football match taking place in South Africa. And so to
rugby, Hope, rugby.
I'm sorry, rugby. And so
did we win, Chris?
Oh no. Well, a big extra thank you to Janieke and Chris for missing out on that to be here with us today. And I just wanted to let everyone know that our next sessions will be starting in just over 10 minutes. So the next general session presentation also has 3 different concurrent tracks. You can hear about Living Well with FOP and the Ability Toolbox program. That's featuring our Family Services Coordinator, Karen Kirchhoff, and 3 community members. There's a session on managing stress and focusing on outlook. This is really kind of focused on mental health and how we can help to control our own outlook and emotions to better our health. And then a 3rd session on FOP observational study updates, where Dr. Bob Pignolo will be talking about the FOP prevalence study, and Dr. Mona Al-Mukaram will be discussing the Ibsen Burden of Illness survey. So I hope you will join us for one of those sessions taking place in just a few short minutes. Thank you, everyone, so much for joining on. I hope you have a great rest of your day.
Thank you. Bye-bye.
Thank you. Bye.